Welcome to Joint Ventures, a sports medicine podcast from Smith+Nephew. My name is Christopher Klifto, and joining us today is Dr. Michael Banffy, a sports medicine surgeon at Cedars-Sinai Carroll and Jobe Institute, and Scott Trenhaile, a sports medicine surgeon at Ortho, Illinois. So, Dr. Banffy.
Yes.
Patients in your practice when instability, are they typically young athletes? Are they older worker comp patient? What's your typical patient population?
For me, it's typically the younger athlete, and that young athlete really could be someone that is quite young, just after adolescence, 15, 16 years old, or it could be somebody that's in their late 20s, early 30s. Very occasionally, I'll have the person that comes to me. I can think of somebody that was maybe 45 and has told me that his shoulder's dislocated, 25, 30 times, and telling myself, well, why am I the first person he's seeing now? And when you hear that story, you know that there's going to be significantly different pathology than that 16-year-old that dislocated once while snowboarding.
Scott, what about you?
I would say it's a similar subset of patients, typically the high school athlete, collision athlete, hockey player, football player, wrestler, all the way up to the super neglected 40-something patient that you just mentioned, and then all the way up to a lot of trauma, actually, that results in severe bony deficits and even into the elderly population. So it spans like the whole gamut of life for me.
How did you build an instability practice, especially for the younger athlete? I know it's not easy to do, especially being in private practice for both of you. That's more of a mature shoulder practice. How does that come about?
I think building what you're really asking is how do you build a shoulder practice, I guess, or a sports medicine practice. And having done a sports medicine fellowship, part of the deal is to cover teams, a lot of teams, and a lot of games, and be around where people need you. So make yourself available and do good work, and it'll all happen.
Dr. Banffy, you have a little bit different setup. You're at a huge sports medicine institute, pillar of that practice. What was your story? How did you get to a great instability practice?
Somewhat of a similar thing. Sure, I have the pro sports experience and the pro sports team coverage I do now, but at the very beginning, it was going to the high school games and getting my name out there and getting to know the physical therapists. I mean, all of the standard ways that you get referrals. That's how I did it from the ground up.
Yeah, and so when you're dealing with instability patients in a professional athlete, right? That's different than your 16-year-old. What considerations do you have when you're caring for that type of patient?
So I think that you have a little bit less of a threshold to see how they do. I think that when you have the 16-year-old that's a non-collision athlete that's come out with one dislocation, sure, you still have the conversation with the athlete and their family about how they're very high risk, but I still think that it is not completely unreasonable to see how they do if all they have is a simple soft tissue injury. Whereas with the professional athlete, their likelihood of coming out is high, but also if they come out again, that's going to be significantly detrimental to their career. And so I'm much more apt to operate on them at the end of the season.
Scott, what's your approach for your trauma patients? You mentioned that you have like an older population that has instability as well. Is it a different mindset than the athlete?
For sure. On that trauma side of things, there's these, multi-system traumas, and typically those folks kind of roll in at the very end when their pelvis is fixed and their hips are screwed back together and everything else has been addressed.
Shoulder's still dislocated.
Shoulder, I've seen that. Yes, I have. But you get into some pretty significant bony defects and capsular injuries and rotator cuff injuries and other things that are all kind of coming together at once. So that's definitely not a sports medicine piece, but your sports medicine training certainly comes in handy when you're working on those folks.
So, Dr. Banffy, I come into your office, I dislocate for the first time. I'm 40 years old. You're not opping me, right? What is your patient population that you're going to allow to non-op for a first-time dislocator? And then what patient population are you going to probably jump right off the bat to do an instability procedure?
So if I take the pro athletes out of the equation, I usually just give them some sort of risk assessment. And so if I have someone that is similar in age to myself, tell them, sure, I like to go to the gym, I like to hike, but I'm not, playing collision sports.
Yeah, like Pilates.
Yeah, exactly.
Yeah.
I got about
silver sneakers.
50% chance of dislocating again. And if it happens again, then we fix it. But pretty unlikely, and I would tell them that if it was myself, I would not have surgery. Whereas if I do have an 18-year-old that is a senior in high school that dislocated, that's planning to go play in college for football, then that's somebody that I strongly recommend fixing.
Same with you, Scott?
Yeah, I would say it's a similar situation. The conversation definitely focuses around recurrence, because we know recurrence is never good. It creates more problems in every aspect of the shoulder. So the conversation for me is all about recurrence and initial workup followed by that piece, and making sure that the patient and the family understand what they're in for.
And I think that recurrence is an important thing, because it's not that it's inconvenient to dislocate. Surely it is inconvenient, but that recurrence will lead to bone loss, but also will lead to arthritis. So that shear stress against the cartilage will lead to problems. And I believe I've read that you could have up to 5% bone loss each time you come out. And so it's not a real simple thing just to I can pop my shoulder back in. It could create a real problem for them if they ignore it.
So someone dislocates twice, are you going to fix them pretty much?
Yeah, there's a strong recommendation, in my practice to repair that.
About you, Scott? Same thing?
For sure. And I'm actually, the older I get, the more aggressive I get with shoulder dislocation.
Is there an age that you're thinking, hey, I'm going to fix this first time? And I know it's not a perfect world, but you said X age, they dislocate, I should fix this the first time around without a huge bony defect. Do you have an age cutoff?
No age cutoff. I think activity cutoff. Yeah. Young collision athlete, 100% fix it the first time. I think they do the best that way.
Same with you, Scott?
I would say, yeah, that's a great answer. And I would just add that they may not even be a collision athlete, but just a contact athlete, or just a hardcore weekend warrior that is 25 years old, and they're going to do whatever they're going to do to get themselves in trouble again. The sooner you can get to those folks, the better, I think.
Now, at the same time, if I have someone that's defensive back, that they're going to the playoffs, it's just going to be a couple months left. I will try to brace them and see if they can play, and then with the idea that we've made this agreement, we're going to fix this at the end of the season.
How successful is that? Are people able to get through the season just bracing after instability events?
So, there certainly are a lot of subluxation events that are occurring that they aren't telling people about that are happening. So I think that it is not as successful as we would like to think it is, but I don't think they're having frank dislocations that require reduction, either on the sideline or in the ER. And, so if there's something that's very important for them from a lifestyle perspective, then I think that you can make some compromises.
Probably depends on their position,
Certainly,
right?
Yeah.
And what sport. So hockey players seem to tolerate it very, very well.
They tolerate everything.
They do.
They don't have an arm, they're happy.
Plus they're down here the whole time.
You're right. So a pro hockey player and I think an NFL football player are vastly different animals, so to speak. So I don't treat NFL players routinely, but I do treat a lot of hockey players. So
yeah. Now, about from a technique perspective, instability. Were you both trained on instability for lateral, beach chair? What are you doing in practices right now?
So my training evolved. I was a resident on the East Coast, so a lot of beach chair, but now I'm 100% lateral.
Same. Trained on the East Coast and then 100% lateral.
Even for cuffs?
Yes.
Me
absolutely too. For cuffs. If you want to see, that's how you do it.
Interesting. I'd love to. I think the audience would love to know what you gain from traction. I'm guessing you're talking about the traction. I know this is
balance suspension, not traction.
Every time I dictate balance suspension in my operative reports, I think of Scott.
Yeah.
So maybe what's the theory of balance suspension? What is that for those of people who don't know what it is?
I mean, it's meant to be a comfortable position for people to rest their arm in that position so you can do the procedure. But invariably, whenever I have people viewing me while I'm doing surgery, they're like, wow, your view is great. And it's not anything special I'm doing. They're in lateral for cuff.
For cuff.
So
let's go over some clinical scenarios here. So you have a first-time dislocator with 4% bone loss. What are you doing? And this, let's just say it's a contact athlete now.
I would encourage them to do most likely a soft tissue repair, depending on what's going on with the humeral head.
Yeah, small Hill sacks.
So soft tissue repair and probably some sort of minor remplissage of sorts. So that procedure in my mind can be titrated up or down depending on what the severity of things are. And it's a bit of an art form actually to do.
Dr. Banffy, same thing for you. You're going to try a soft tissue procedure in an athletic person who probably will have like, contact sports.
Yeah, I agree with Scott. You know, I think the 4% bone loss, the small Hill sacks, you're that near track category. We've shown that doing a remplissage with that does add stability, less recurrence. So I think it's smart to do. You just got to do it right.
Well, that's the question, right? Because we know that the recurrence rate could go up to somewhere 21, 25%, right, for soft tissue Bankart repairs. What do we have to do to make those procedures successful?
Well, I mean, I think the anchor placement, where, you know, making sure that you're addressing the entire zone of pathology with regard to your glenoid. You know, I think that it really depends upon the athlete and what sport you're dealing with. You know, for example, if I have a baseball player that's overhead, I'm not going to do a big, massive capsular shift. I'm just trying to repair their labrum, you know, where it anatomically belongs. On the flip side, if I do have a collision athlete that I really want to create some stability, and I'll do an inferior shift and tighten him up as much as I can. But then adding that remplissage in a soft tissue procedure, I think is beneficial. You know, we had talked about this earlier. I think that you can screw it up and have decreased range of motion if you put your anchors too medially. So you have to be very wise on where you put your anchors with the remplissage to have the best outcome.
So could you elaborate on that? Because maybe Scott, you can elaborate too, but I think that's the biggest concern we have with the remplissage, right? Like it's great for stability, but maybe for the overhead athlete, they lose some external rotation, they can't pitch. One, do you think that's real? And two, how do you prevent that? I know you kind of touched on that briefly, but Scott, what do you think?
Yeah, like I said, I think remplissage is a bit of an art form. There's several places you can fall down. So placement of the anchors, of course, and also where you penetrate the posterior capsule and infraspinatus tendon, and also, you know, possibly even catching the fascia of the posterior deltoid. So you need to know what layer you're in and where you are, and make sure that you're not too medial and basically capturing the joint, which is always bad. I mean, it will make things stable, but it won't make them good. So technically, there's places where you can fall down, and that's a whole nother topic. I think that we could spend a lot of time on. Yeah.
What anchors are you using for your remplissage?
So since the Q-FIX Knotless came out, I use the Q-FIX Knotless Suture Anchor, not the tapes. In my limited experience, I've been placing one inferiorly, one superiorly after I prep everything, and basically crisscross the sutures into the other anchor, and then pass the sutures, but try not to pull all the way.
Right.
Do the work in the front of the shoulder, and then come back at the end and just pull, and you're cut, and you're done.
Yeah, the pull-out strength is fantastic with that.
It's surprising because I always thought that I'm in the humeral head, the head is depressed, so I should use a rotator cuff anchor, so like a helicoil or something like that. So I used to use a 475 helicoil, and frankly, it's great. I'm done. I'm moved on, and this is, I think, how I'm going to do it.
Yeah, it takes like 5 minutes. What about you, Dr. Banffy? Same thing?
So I'm intrigued by utilizing the knotless technique. You know, I've thought about it, I've talked about it a lot to people, but I still have not gone that route yet.
Well, what do you use now? Because I think that most people are using knotless, so I'd love to hear your technique.
So I still use a 2-weight Q-FIX, and I usually will use 2 of them, one at the most inferior aspect of the hill sacks, one superiorly. They're double loaded. I usually will pull out one of the sutures, and just so I have different colors on either side, so I know what I'm tying, and then bring those through with a bird beak. And then with that, I can really pull on the humeral head, or have my assistant pull on the humeral head if I need to access the front. So it's nice. I don't know how easily you can do that if you've already passed your sutures through with the other technique. But I really like the knotless technique, and you know, the more and more that I use the knotless Q-FIX, the more and more applications I see benefit for it. You know, I've been using it in the hip, I've been using it in the knee, I've been using it everywhere besides the shoulder as well.
I'll give you a little tip of why most people are using it, because the knotless is easier. So that's why I think people are moving to knotless. So now let's talk about the labral pairs for anterior posterior labrums. What anchors are you both using currently in your just standard anterior labral pair? Dr. Banffy, you want to take that?
So I've merged completely over to utilizing the Q-FIX knotless with tape. There's been an evolution of the anchors that I've utilized from utilizing hard body anchors. I mean, I'm not old enough to have ever used metal anchors, but I certainly have used PEEK and biocomposite anchors in the labrum, both anteriorly and posteriorly. And I would tie. Then that transitioned over to all suture anchors that I would also tie. And then that started transitioning over to our knotless all suture constructs. And then, really the knotless Q-FIX is the pinnacle of evolution on that. And it's a really good anchor.
I was never a generation where we had to tie knots. What do you notice in your patient population when you actually tie knots for labrum? So they have mechanical symptoms or no, post-operatively?
If you do it right, no.
Exactly.
Keep the knot off the face.
So you're saying if you're a good surgeon, patients will do well?
Exactly.
Got it.
I mean, it's not that easy, but yeah, I mean, I am old enough to have seen metal anchors going into glenoids, and we've tied knots for years and years and years and years and years, and just like you said, this is like we're at the pinnacle of evolution here, where we've finally got an anchor that doesn't pull out. You can tension it and retension it. You can come back and tension it again.
Well, I want to ask you about that. So what's your technique? Do you place all your anchors?
Dry dock each.
You dry dock each one?
Dry dock each one, and then you can kind of assess, like, yeah, it looks good, or I'm gonna go back and revisit each one of these, and I did that a lot when I first started using the anchor, because I was trying to get confident in it and make sure that it was going to work for my application.
And you find out you get more tension when you dry dock it and go back?
Not really. That was what was so.
So why do you do it?
So that's
well, it was a learning. Like
too.
It was a learning. It was a learning curve, right?
Yeah,
Like,
with other all suture anchors that are knotless, I would find that I'd get sometimes even a centimeter of excursion after the fact, which was like kind of shocking.
At the end, what do you really?
disconcerting,
And
right?
so then I was doing that, but then since I've switched over to using the Q-FIX knotless, they don't budge. Like
that was
once
my
you
point.
get it, you get it.
Yeah, I haven't had to dry dock, and actually because it kind of cinches and stays down with this anchor. It's been great. What about for superior labral tears? Are you using different anchors, or is it the same knotless anchor?
In the rare instance that we do superior,
Oh, that could be my next question.
I think that for me, that surgery is the whole top half is torn off. So 3 to 9 o'clock, like it's real and it's really big, and you start fixing. Otherwise, you just try to stay behind the biceps tendon, and oftentimes it's more of a posterior labral extension, so to speak. But I think it's all the same in terms of anchor choice.
I mean, for about you, have more of a population where you're fixing superior labrums?
So I think that if you have true pathology there, and sometimes in throwers you will see it, and you need to fix it. I don't like doing it, and it certainly makes me feel uncomfortable in it. So I usually will still use a circumferential type configuration just posterior to that biceps. If there's pathology in the front, I'll do the same thing. But at the biceps, I don't want to constrain it. So what I've done, I just have done this recently, is with the Q-FIX knotless, pass it through in a mattress fashion. So then that will tension that part of the labrum back down, but still give that meniscoid appearance to the top of the labrum. That seems to have worked well.
Yeah.
Awesome. So let's talk about more complex instability cases. Now we have a patient that has, let's just say 20% bone loss, first-time dislocator. We're going to say this one's a combat athlete, a UFC athlete. Are we thinking this is a bone block procedure? You're going to try any soft tissue procedure for them? Dr. Banffy, you want to try that one first?
So when I think of bone blocks, I'm really thinking either an allograft or a Latarjet. That's my practice at this point. And if they've had multiple dislocations and the soft tissues are not great in the front, I actually really prefer the Latarjet. I think it's a good procedure. Now, if they have a ton of bone loss, then we need to build that back up. So then I'll start transitioning over to utilizing an allograft. But
what's your percentage where you're going to thinking more distal tibia allograft?
In my practice, it's probably 80% Latarjet, 20% DTA.
Percent.
Or let's talk about percent of bone loss. I would say 30%.
30%. What about you, Scott?
Very similar. I think as my own bone block experience continues to expand. I mean, I've been around long enough that we never did bone blocks for anything. And now it's come to that very scenario where the soft tissues are poor and you're relying on the Latarjet to take up the bone block and whatever else you can get from the sling effect. But it's the like a distal tibial allograft for the real large defects. But then also when you get into the subcritical bone loss, it's nice to put one down there and then fix the Bankart where it's supposed to go in an at-risk athlete that's young and you're just like, maybe Latarjet seems like an overkill, and you don't want to subject them to violating the subscap, and you just want a little insurance. So it's kind of on the high end and on the low end, and then you got Latarjet in the middle.
A lot of debate between how you fix a Latarjet. Are you using screws or buttons at this point?
Well, again, I've gone back and forth and back and forth. So
where are you now?
Back and forth and back and forth.
What are you doing tomorrow if you have one?
Well, it's funny. I just did one on Monday, and to me, I think it's multifactorial, but the morphology of the glenoid bone loss, I think, plays into this as much. So if it's a vertical bone loss versus real, anterior-inferior, and I think all these different factors, I probably overthink it, but I'm trying to figure out who needs one screw, who needs two screws. If you put in two screws, will the patient actually load that bone and heal that bone? Mm-hmm. So I go back and forth in an individualized manner, I think.
Michael, what about you?
100% button.
Okay.
Yeah, so I usually
elaborate on that?
Yeah, one button for Latarjet, and I'll use two for the DTA.
Okay.
And the reason why is I'm doing them arthroscopically, and so it's very easy to pass that. That's reason number one. Reason number two is I've just seen so many complications with broken screws or bent screws and having to deal with that. It's a problem, and if that screw violates the joint, that's another problem that you don't really have to worry about with the buttons. And the healing rate of the buttons, particularly with the Latarjet, is very good. I mean, with that native bone, I've not seen any that haven't healed. Now, there can be a delay of union, and I'll routinely get CT scans at 6 months, and I won't see complete healing. But then,
for all your patients, CT scans at 6 months.
Yeah, just I've done it since I started transitioning over to arthroscopic Latarjet. But those do heal, and I'll get a CT scan at say a year, and I have not seen one with a non-union. On the flip side, I have seen some of my distal tibial allografts dissolve, and that could be a form of fixation, but I don't have a cohort of screws to compare it to. I know it has been described that may be an issue, but I also think you could argue that not all of these bone blocks will heal. And if they don't heal, I'd rather have it be a button that's in there than a screw that is going to cause another problem when I'm having to do the revision.
Arthroscopic Latarjets are a procedure that I just don't consider myself to be good enough to do. What was your learning curve to get to that point? Because I'm still going to do them open every time because, one, they're easy. How did you get to an arthroscopic point where you're like, hey, what's your time like right now? And how many did you do to feel comfortable?
So I did not believe in it at all when I first heard about arthroscopic Latarjet. And part of that was some of the techniques that were out there really were seek and destroy on the subscap with obliteration of the capsule, massive hole within the subscap. It just didn't make any sense to me at all. And doing it open, does not take that very long. But doing it open also is a big dark black hole sometimes, and it's not the most satisfying sticking your finger in there, making sure that it's flush. So I saw Pascal Below demonstrate his technique utilizing a 70-degree scope. I also am a hip arthroscopist, so I'm very familiar with the 70-degree scope. The instrumentation that is available through Smith+Nephew really is a safe, guided system. And so, although there are 25 steps, and you got to follow each one.
There's 5 steps. 5 simple steps.
That as long as you do that,
then you have a 20 free if you don't do it right.
It comes out quite nicely. Now, I did a case with Pasquale, then I did probably 5 more cadaver cases before I did my first patient. But I've never had to convert to open. I was very dogmatic at the beginning where I wanted to do it exactly as he did it. And I've changed that fairly dramatically. And so what used to take me probably 90 minutes, maybe even 120 minutes, now has gone down to closer to probably 75 minutes. And what used to be the big learning curve for me was finding my spreader when you're putting a spreader in from posterior to anterior in the front, which is a very foreign view. You don't really know what you're looking at. But now I have my camera in my top portal. I just sneak it right over to the other side, and you can see the spreader right there. And once you see that, it takes 2 seconds. Then you just saved half hour on the case. So I'm real comfortable with them now. It's not a case that I worry about at nighttime. Probably maybe 40 to 50 of them under our belt at this point. But it's a procedure that I'm very happy with. It's worked quite well in my practice.
Do you think the sling effect is real with a Latarjet?
I do.
For sure.
Yeah.
Yeah.
For sure?
For sure.
For sure?
I mean, I've done Latarjets on people
For sure strong, Scott.
For sure. Because like when you go in on a case where there's like no capsule, no labrum, it's just nothing there. And you do the ladder, how could it work? How could it not assist in some way, shape, or form?
I think if you have somebody that has no bone loss, but has no capsule, just transferring the conjoint tendon probably is very useful.
Yeah, it's just interesting. There's been a good number of studies out there now saying that probably doesn't mean anything, especially with the success of DTAs, but it kind of has to, right? It makes sense from an anatomy perspective.
You know, I lived through the radiofrequency ablation striping of the capsule, and then it would dissolve and go away, and then we'd put the camera in later, and there's like subscap muscle, and that was like 2002, and we didn't really do Latarjets then, and I think it would have been interesting to see how those folks would have. We were trying to reconstruct the capsule with Achilles tendons and doing all kinds of crazy stuff to get back to ground zero, but I think that a Latarjet would have done well.
And it's not just the sling, it's also that subscap tenodesis. I think that both are important for the stability.
Why do you think a DTA works then so well? If it doesn't have the sling effect, why is there so success? Or do we put too much stock in the DTA? Is it not as good as we think it is? Scott, you want to take that one?
I think we make them big, and if you can get them to heal, there's just a huge amount of real estate for that humeral head to go. Plus, honestly, if I'm doing one like that, I'm also remplissaging pretty aggressively. Because it's a salvage procedure at that point, and you're trying to do whatever you can to keep things in.
You're both remplissaging with your Latarjets?
When needed.
Yeah, if it's
not routinely.
If it's a big Hill Sachs, but not routinely.
Interesting. Still based on the Hill Sachs. For athletes that have a Latarjet procedure, one, I'd love to hear both your opinions. What's the return to sport? And let's just say, example one is contact athlete, example two is overhead athlete. Who's going back with a Latarjet?
Mine are mostly contact athletes, probably not really overhead athletes.
Yeah, that's a good point.
Honestly, for me.
What's the return to play with the Latarjet? And we'll just say with contact athletes.
I mean, there's a protocol that we have in my organization, and we try to follow it, but it becomes individualized. Particularly, we see this with pro hockey players. That's where the majority of my experience has been, and they want to go back at 5 months or sooner.
Do you let them? What is your return for hockey?
We have actually, we haven't published this, and I've been wanting to do it for a while. We have our own specific return to play and return to ice protocol that is different than rehab. It's just more about, you have your rehab protocol, but then you have you can't do much with your arm, but they're already back on the ice as quick as possible because they want to keep their legs and their cardio and their core and everything else strong. And it's a kind of a different philosophy, but it's tricky because you're always wondering, like, I do a lot of CT scans afterwards to see if things are healed, because ultimately that's where you win or lose, I think.
What about you?
Yeah, I usually say 6 months. And I was basing that originally on the CT scan. So if the CT scan didn't look healed, I'd be cautious and gosh, maybe we should wait. But then I figured that was silly because I wasn't really getting CT scans in my open Latarjets, and I was just letting them go back as long as they had good range of motion and strength. So I think that as long as they have good range of motion, strength, they can protect themselves, they can go back even with a fibrous union. And I haven't had a problem with that.
Well, that's my question for you. But you both get CT scans. I don't get CT scans. I just stick my head in the sand. If you're doing well, you're doing well. What happens if you have a non-union at a Latarjet at 6 months? Are you going back and revising it if the patient's doing clinically well?
No.
Yeah, if they're doing clinically well, they're fine, and it's a fibrous union, and it's not going to budge. I'm getting the CT scans for research purposes.
Yeah. And I've gotten less and less of these as I've gotten, further down the road in my career. So it's not I don't think it's a set thing, do you, in terms of
not at all.
What we're supposed to do and how we're supposed to do it? But
how do you prepare the anterior glenoid with the DTA or Latarjet? And specifically, my question is, there's been some studies out there saying that you should use PRP or some BMP or whatever it may be to promote healing. Do either of you do that for your bone preparation?
I haven't.
I mean, to prepare the anterior glenoid with the Latarjet, there's a rasp that's utilized that actually works really nice. When I'm doing a DTA, I don't have that rasp. I'm not usually opening that package. So I'll just use a burr to prepare it and try to make it as flat as I can so that the contour of it matches the graft that I'm putting in there. You know, I think that there is a thought though with the allograft, and maybe that's one of the reasons that they fail. You know, if you soak it in some BMAC, I mean, I certainly have done that in osteochondral grafts in the knee in a revision setting that I'm worried about it healing. So probably does have a role, but certainly needs more studies to support it.
There's some talk of taking those grafts after you've, say, used a saw, there's sawdust and whatever that you stirred up with preparing that. You could use pulsatile lavage to kind of work all that out of the bone.
You know, I've used that, but I also have transitioned over to utilizing high pressure air, and that gets all the fluid out of there. And then if you put the BMAC or the PRP on there, it actually absorbs into the bone. It's pretty cool.
From a Hill-Sachs perspective, that's like the hot thing right now. If you see a Hill-Sach, I don't know, do you have a percentage that if you see it, do you do a remplissage? Or do you kind of just still go by the on-track, off-track criteria? What's your algorithm for doing any sort of Hill-Sachs treatment? And does it change your PT protocol after? Scott, you want to go first?
Again, I view that as sort of an art form, and it's a terrible answer, but it's true. It's a multifaceted decision by looking at the CT scan, getting the calculations from my radiologist, who's very diligent about giving me all this data, like the Hill-Sachs is this wide and this deep and this long, and it's this far below the equator, which makes your risk of arthroscopic whatever more risky, and da-da-da-da. And then when you put the scope in there and you see the type of tear, the extent of the actual instability that the patient has on an exam under anesthesia, all those factors sort of play into it. And it always blows my mind when people say, I just want to learn from you how to do rotator cuff surgery because I got instability down. I'm like, wow. Like, I think instability is hard. Just in many ways, it's complicated.
Yeah. Well, you Michael, same thing?
So it certainly doesn't change my rehab. And I've gotten much more aggressive on moving these patients early. I try to, have them move their arm in the plane of the scapula within like 2 weeks. And that doesn't matter if they had a remplissage or not. But I completely agree. It really, you can have a thought in your head of what you're going to do, and that'll, sometimes I'll just say, shoulder instability, anterior capsulorrhaphy on my consent form. Sometimes I'll say possible remplissage. Sometimes I'll put remplissage for sure, and I have this thought process in my head of exactly what I'm going to do, but I still will modify it based upon what I see intraoperatively.
Yep.
You do your primary Bankart, patient comes back in, and we could just say now they have 12% bone loss. They dislocated again. What's your algorithm and treatment? Maybe Scott, you go first, and then Michael, for the recurrent dislocator.
I mean, the recurrent dislocator does fairly well with Latarjet, and it's interesting that there was a paper that just came out at the end in December, Journal of Shoulder and Elbow, that talked about you should do an arthroscopic Bankart first, because if you get a dislocation, follow-up Latarjet is like 4% recurrence thereafter. And it was a little vague how that all got described, but it's kind of true. Like it's a great solution for a recurrent dislocator after arthroscopic repair. Is
that your revision strategy of choice usually?
So for me, it depends upon how the first surgery was done. If it was a poor first surgery, where you look at the operative report and it wasn't my case, and there's
what if it's your case,
one anchor placed or something like that, then I may try to revise it with another soft tissue procedure. But if it was my case, clearly it was done extremely
perfectly.
well.
Clearly,
yes.
Then I completely agree. A Latarjet is my next step.
Yeah.
And I bet you I actually have done more Latarjets in revision settings than I have primarily.
And the data's good on that.
Yeah.
I mean, independently of what I just mentioned, it's very good.
Yeah.
What do you make of the European literature where they have almost a 1 to 2 to 3% dislocation rate or redislocation rate after Latarjets and advocate for that as a first-time surgery? Is there any validity to that? I mean, obviously, their data shows that. What's your take on it? Michael, you go first.
I believe it. It's a very stable procedure. I think if it's done correctly, that you don't have a significant loss of range of motion. I think if you do it arthroscopically, you can put the bone block in the perfect position every time, and so your risk of arthritis, should not be there. I don't know if we have any long-term studies looking at arthritis rate in that population. But the only thing I'd really be concerned about. But I do think you're changing their anatomy. You are taking unnecessary risks that you don't necessarily need to have, because I think that a soft tissue Bankart procedure in the appropriate setting works very well.
And it boils down to the sooner you get to that soft tissue Bankart, the better.
That's right. Yeah.
The sooner you get there, the better.
When you're talking to your athletes and you tell them you're going to take a piece of their scapula, you're going to put it on a different part of their scapula, are they okay with that? The athletes? Is that fine for them?
Yeah, I mean, most of them, understand that you're trying to stabilize their shoulder, and I have this technique where I can move some bones around, and it makes it very stable for them. And I would argue in your hockey players that they have one side done, there's maybe a revision, and they dislocate the other side. Can we just go to the
yes,
ladder J?
100%.
Mm-hmm.
Straight to ladder J.
So I have this weird population of patients that want to have the hockey player that's that exact scenario. They're in juniors. They get a Bankart on one side when they're 15, 16, 17, whatever age it is. Now they're 23. They're playing in the AHL, going up into the NHL, back and forth. And they come with the other side, and they just want to go straight to ladder J. The other one are these pro water ski jumpers. And I got a bunch of them. It's this craziest thing where they jump for money. The farther they go, the more money they make. And they do, barefooting where you start backwards and all that crazy stuff. And they all want ladder J because their friends all have it.
So let me get straight. So it's the long jump, but
they hit the ramp and they fly, and then they 250 feet, however far they go. The farther they go, the more money they make.
In a lake in Illinois,
Wisconsin usually, but yeah,
clearly Wisconsin.
But some of these guys, they go to they're on the United States water ski teams. They go to China and Asia and Europe and all over and compete, and they mess. I just had one last week. The crazy bone loss, crazy big Hill-Sachs lesions. Talk about extreme energy. You hit wrong. So in those folks, they'll come in and they'll say, I did this one. I want the letter J in this one. And I don't argue. I just do it.
And that's after them having failed a Bankart or a successful
No, they just dislocate, and they've done it a lot, and they come in. And sometimes they don't have that much bone loss. One of my employees is the exact same. That's the story. And he just came in. He's like, I want ladder J on the other side. I said, okay, we're doing it.
For professional athletes, is it the same? Do they sometimes come in for preference? They have agents. I mean, that's a world that I'm happy I'm not a part of. Do they come in and tell you what procedure they want you to do?
Generally not. I mean, not in the agent referrals that I'm seeing. Because I see a lot of baseball players and a lot of football players, and
he's seeing the patients that they saw me first, and they're like,
You just wait till he steals your water skiing population.
Yeah, I focus on the exotic dislocator.
So those patients come in and they're pre-receptive to, and then how successful are soft tissue procedures in the baseball player and the football player?
So I would say that with regard to baseball, you really hope it's a soft tissue procedure, because if you have to do something else, that's going to change their career. It's going to, I don't care if it's distal tibia allograft or ladder J, it's just going to be a different shoulder that they have, and it's not going to be the same shoulder that they once had. With football, it's going to be position dependent as well, yep. But they're able to tolerate it a lot better.
I have a quick question.
Yeah.
So probably a year ago, I had a college baseball player, non-dominant arm, dove for ball, 11% bone loss. But it looked bad, even though it was only, it was one of those where you look at the CT and you're like, In that patient, I did a Bankart with a DTA with buttons. So it was like belt and suspenders.
Mm-hmm.
And his motion was really good because we didn't really alter the anatomy. It didn't make the bone block that big. That's kind of that subcritical bone loss patient I was discussing. I mean, do you ever do that with your players?
So it was a non-dominant arm?
Non-dominant arm.
How'd he hit?
He's a pitcher, so he tried to avoid a bat as much as possible.
Yeah, I mean, that's a reasonable way to go.
Yeah.
And so you just really lucked out that
Yeah, I did.
he doesn't do much with that arm.
Yeah,
so.
correct. But he's super scared. I think he had a lot of anxiety, and this was interesting. His situation. He was adamant about not having screws. He didn't want. He knew all about broken hardware. He knew all about broken screws and problems. And I was like, well, I got a solution for you, and it was buttons, double button DTA with a Bankart repair over the top.
Arthroscopic open?
Yeah, arthroscopic. Yeah. I think once you start down that road, it's surprisingly easier than you think. As long as you do the whole peel, release the labrum at 11 o'clock or 1 o'clock with a traction stitch, and the whole thing opens up, which is nice. Yeah. That was probably my aha moment, was when you can really skeletonize the front of the scapula to kind of make way for this block, whatever you're bringing in.
So here's a question with DTAs. When you're repairing the labrum around them, are you placing an anchor in your bone block, or are you utilizing like a suture on the button? Because otherwise your capsule is going all the way over that cartilage.
You can't though. I mean, I don't put anchors in the bone blocks ever.
No, I don't. I think when you do it, everything ends up being more inferior.
That's right.
Or distal, I guess. Inferior. It's not up where you would put a Bankart repair, so it's more of just like a hammock. That's how I think of it
tissue,
anyway.
Yeah, the tissue is usually not high quality. It's usually not completely intact. So, well, this was a wonderful podcast session. This is a joint venture sports medicine podcast. Dr. Trenhaile, Dr. Banffy, thank you so much for your insights on shoulder instability. They were wonderful. Thank you for joining us.
Thanks for having us.
Thank you very much.